Now, when you have a problem inside the kidney, that problem inside the kidney can be from direct acting toxins on the kidney. It can be from allergic interstitial nephritis. It can be from pigments, hemoglobin, myoglobin, red blood cells, hemoglobin, myoglobin, toxins, allergic, pigments, crystals, urate and oxalate, calcium, and calcium itself is directly toxic to kidney tubules. So the difference in a person who has tubulointerstitial disease, let's see, acute tubular necrosis, okay, is a combination of direct tubular damage on the basis of the toxin. It directly burns the tubule. The damage is tubular, meaning that acute tubular necrosis, the toxin acts like a sunburn on the tubule. It burns the tubule directly, combined with decreased perfusion. That's why having surgery and hypotension and hypoperfusion results in a person who has an increased BUN and creatinine just on the basis of hypotension and hypoperfusion. Decreased drainage, post-renal renal failure, or a combination of these two things. But remember, kidneys die from hypotension and kidneys die from toxins, and if you have hypotension and hypoperfusion combined with the toxin, they die even more. Now, oliguria is defined as having somewhat less than 600 cc's a day of urine output. And having a completely dead kidney or anuria doesn't mean zero urine output, it just means less than 100 mLs per day. Now, if somebody manages to recover from all of that oliguria, all the fluid that they didn't urinate out for the last couple of days comes pouring out, and post-oliguric, they're going to urinate out all the fluid that they didn't urinate out before. So acute tubular necrosis, the BUN and creatinine ratio, instead of 20-to-1, will be closer to 10-to-1. The urine sodium, instead of being low, the urine sodium is going to be high. And in all these tubular damages, acute tubular necrosis, the urine osmolality is going to be similar to serum osmolality. That's called isosthenuria. Isosthenuria. Iso, the same. Stenos. Stenos is the Greek word for strength. Stenos is the Greek word for strength. Urine. Isostenos uria. It means it's the same strength as the blood. You can't concentrate and you can't dilute. That's why the urine osmolality will be like serum osmolality. Isostenos uria. Now, here's a table showing the difference between pre-renal and acute tubular necrosis. Here you're concentrating the urine. Cold on hot summer days, pee-pee get dark. But in acute tubular necrosis, what cell in the kidney concentrates and dilutes the urine? And the answer is the proximal tubular cell and the thick ascending limb of the loop of Henle. So if you have a person whose kidney tubule has died, they cannot concentrate and they can't dilute the urine. Because what concentrates and dilutes the urine? The tubular cell. If the tubular cell is dead, it can't concentrate the urine. Now, sediment is something that we didn't say much about before because it's the least useful thing. You see this where it says muddy brown, pigmented, or granular casts? What are the granules? What are the pigments? What are the pigments and the granules and the muddy brown casts? Muddy brown, pigmented, granular casts, these are basically the cadavers of tubular cells. They are little tubular cell corpses. They get sloughed off and put into the urine. They're dead bodies in the mass grave called your bladder. So in ATN, when the kidney tubule dies, they slough off and go into the urine as pigmented or granular casts. Now, acute tubular necrosis. Cells are living entities lining the tubule, like your skin cells, but in the interior of your tubule. No perfusion, they slough off and die. Toxins, like aminoglycosides, pigments, myoglobin, hemoglobin. They get sloughed off and they die. Now, overall, when you see treatment for acute tubular necrosis, well, these are the three sort of commonsensical things to do. Remove the effect of the aminoglycosides, water them, supportive care. I like that. No, honey, I still love you when you're on dialysis. That's supportive care. But the real issue for treatment for acute tubular necrosis has more to do with what doesn't work. So the difference between Step 2 USMLE board review and ordinary knowledge and caregiving is that we're just as interested in the wrong answers as we are in the right answers. For instance, what does not work? Low dose dopamine. Yes, low dose dopamine should work. It ought to work. Low dose dopamine increases splanchnic and renal perfusion, but it does not decrease renal failure. Diuretics does not work. You may urinate, but it doesn't prevent or reverse the renal failure. Mannitol doesn't prevent or reverse the renal failure. So mannitol, diuretics, low dose dopamine does not reverse or treat the renal failure. You hydrate them to prevent any degree of pre-renal azotemia, and then you wait for the kidneys to get better on their own. So acute tubular necrosis is a combination of hypoperfusion, maybe with the toxin. Now, allergic interstitial nephritis. Fundamentally, the difference between allergic interstitial nephritis and the other toxins is that in allergic interstitial nephritis, you don't need 5 or 10 days for the toxins to build up. Allergic interstitial nephritis can happen from the first dose. Now, that's the difference between a penicillin, a sulfa drug, allopurinol, phenytoin, rifampin. Penicillin, sulfa drugs, let's look at this slide. Penicillin, sulfa drugs, allopurinol, phenytoin, rifampin, is that these are allergenic substances, and one dose can do it. Now, what's the difference between that and something like, let's see, aminoglycosides? Aminoglycosides like gentamicin, tobramycin, amikacin, gentamicin, tobramycin, amikacin need 5 to 10 days to build up. Now, allergic interstitial nephritis, what's the difference? They happen right away. Allergic interstitial nephritis, hey, what substances are human beings allergic to? Human beings are allergic to penicillins and sulfa drugs. 10% of the general population is allergic to penicillins and sulfa drugs. What causes Stevens-Johnson syndrome? Penicillin, sulfa drugs, allopurinol, rifampin, quinolones. What causes drug-induced hemolysis? Penicillin, sulfa drugs, allopurinol, rifampin. So, ready? Now you can look at this as 3 separate things and learn them in 3 separate tapes. The drug reaction section and the rashes in the dermatology section. You can learn this here in the allergic interstitial nephritis section. You can learn it again in the hematology section. Or you could say, no, it's the same drugs that people are allergic to. What drugs don't cause allergic interstitial nephritis? Beta blockers. People are just not allergic to beta blockers. Beta blockers don't cause a rash. Beta blockers don't cause Stevens-Johnson. Beta blockers don't cause hemolysis. Calcium blockers, people are not allergic to calcium blockers. They're not allergenic. People don't develop a rash from calcium blockers. People don't develop hemolysis from calcium blockers. So there are drugs that people are allergic to that cause rashes, Stevens-Johnson, toxic epidermal necrolysis, hemolysis, and renal problems. You can learn them as 3 separate things. But it is better to say, you know what? They're all the same thing. To see a world in a grain of sand and heaven in a wildflower, hold infinity in the palm of your hand and eternity in 1 hour. The kidney, the skin, the blood, allergic interstitial nephritis. What is different? These people have a rash. These people have a rash. These other people don't. These people have a fever. These other people don't. These people have increased eosinophils. These others don't. What is different? What's unique? What is different? What's unique? What's given me the answers that I seek? What is different? What's unique? Fever, rash, eosinophils. First dose. Thank you very much. Thank you very much. Thank you very much. Thank you very much. Now, allergic interstitial nephritis rarely can also be from infections. So when you see here it says infections, viruses, bacteria, fungi, Legionella, Rickettsia, Streptococcus. I think we're back to the Dalai Lama and the hot dog man. Make me one with everything. That's saying that all infections could do it. All infections can do it. Autoimmune diseases can do it as well. But the most common thing to cause allergic interstitial nephritis is drugs, medications. Next slide. Well, what's different about allergic interstitial nephritis? Fever, rash, joint pains. Well, joint pains is part of any form of serum sickness-like reaction. Increased immunoglobulins. Now you get increased eosinophils in the blood, eosinophilia. Do you love your eosinophils? Are you a eosinophil lover? Oh, my little eosinophil, how I adore you, how I cherish you, how I love to stroke your lobes and your eosinophilic inclusion bodies. Oh, my eosinophils, I adore you. Eosinophilia, I love my eosinophils. Now, what's more common? Eosinophilia, to love my eosinophils. One of the three Greek words for love. Philos, eros, agape. I love my eosinophils. Or, frankly, is it more likely that eosinophils in my urine? Eosinophiluria. Is it more likely common in the blood or in the urine? The blood and the urine. Which is more sensitive, in the blood or the urine? And the answer is urine is more often found than blood. Eosinophils in the urine. Now remember, IgE levels go up, but when the question says, which of the following is the most sensitive? It's eosinophils in the urine. What is the most sensitive? Eosinophils in the urine. IgE and eosinophils in the blood are present, but they're less often found. Ready? What is the best initial test to determine the presence of eosinophils in the urine? Urinalysis. Urinalysis. The urinalysis sees the eosinophils in the urine. That is the best initial test. However, the urinalysis cannot distinguish whether they are eosinophils or just white cells. They can't tell if they're eosinophils or just white cells. So you ready? What's different about allergic? Rash, fever. And you go, yeah, come on, man. Anybody who's got an infection can have a fever. Yeah, but they don't get allergic drug rash. Well, then they don't have eosinophils. So therefore, eosinophils in the urine is the best initial test. However, you can't tell that they're eosinophils on a regular urinalysis. For extra bonus points for the brand new car in the dream home in Westchester, New York, what is the single most accurate test for eosinophils in the urine? It's a specific test called a Hansel's test. Hansel's test. Oh, no. Don't you look at me in that tone of voice. Yeah, Hansel, like Hansel and Gretel. Just because you never heard of it doesn't make it wrong. Okay? And as we say in the review course business, hey, you cannot review what you never knew. Okay? So Hansel's test. Hansel's test, as in Hansel and Gretel. Hansel's or right stain. Hansel's or right stain is the test to look for eosinophils in the urine. Now, the most accurate test is a biopsy. However, biopsy not necessary. Biopsy not necessary, like television on honeymoon. Not necessary. Also, why should I take a piece of my kidney when I can just give up a little piece of my urine? Okay? Now, the treatment is like with most allergic things, just stop the drug. Stop the drug. Just say no to drugs. And it should stop for you. If the kidney failure continues to progress, you may use steroids. But the question has to say you stopped the drug and the BUN and creatinine continued to rise. Dialysis is coming soon. I really despise. So therefore, if your BUN and creatinine are still rising after you stop the drug, you may try a trial of steroids. Allergic interstitial nephritis, penicillin, sulfa drugs, allopurinol, phenytoin, rifampin, quinolones are what we're allergic to. Check for the eosinophils in the urine. Number one, blood less. Hansel stain. Stop the drug, should get better. Doesn't get better? Try some steroids. Now, pigments, hemoglobin, myoglobin, rhabdomyolysis. Here is going to be that question, okay? You have a 27-year-old man who has just run a marathon. He has just run a marathon, and at the end of the marathon, he has a seizure. And during his seizure, he is hit by a truck that is carrying pravastatin, fluvastatin, simvastatin, atorvastatin, cerevastatin. What is the most important thing to do for this guy who's got a terrible crush? He's been terribly crushed. Oh my God, I've got a terrible crush. How would you do? Remember, when somebody has a terrible crush, what's the first thing to protect? The heart. When someone has a terrible crush, the first thing is to protect the heart. Because how do you die of a crush? Oh, you feel achy and painy all over. You feel like you'll never recover. You feel like you'll never urinate again. Ha ha ha, never gonna urinate again. Oh, my BUN is rising and my creatinine is too. Feel like I've been crushed. I feel like I've been hit over by a truck. When you have a crush injury, a terrible crush, the first thing to do is to think about the heart. The kidneys later. Renal failure, remember, if you have anuria, your kidney's creatinine only rises at 0.5 to 1 point a day. However, if you have a severe crush injury, you die today of? How you die immediately after that crush is from potassium. You see here, hyperkalemia. Hyperkalemia because 95% of the potassium in the body, is it in the cells or outside the cells? 95% of the potassium in the human body is inside the cells. So when you have a terrible crush injury, your best initial step should be to either say, get a potassium level or check an EKG. Because if there's a hyperkalemia and EKG changes, you're going to say, give calcium chloride, calcium gluconate, calcium chloride, calcium gluconate, calcium chloride, calcium gluconate. Now, that doesn't tell you have rhabdomyolysis. The best initial test to see if you have rhabdomyolysis is the urinalysis has a dipstick that's positive for blood. And the dipstick that's positive for blood, but I don't see any cells. Now, the dipstick positive for blood, but no cells seen, is because the urine dipstick cannot tell the difference between hemoglobin, myoglobin, or red cells. Hemoglobin, myoglobin, red blood cells. Hemoglobin, myoglobin, red blood cells. You can't tell the difference between hemoglobin, myoglobin, or red blood cells. So therefore, you have a dipstick that's positive, but no cells are seen. That's what you do immediately as the best initial diagnostic test, for rhabdomyolysis. So let's be clear on this, because I know it can be difficult. Ready? Severe crush. The first thing to protect when someone has a severe crush is the heart. Is to protect the heart from potassium and arrhythmias. Now, high potassium and peak T waves are non-specific. The best initial test to make a specific diagnosis is dipstick is positive for blood, but no red cells are seen. You might say, well, how do you know it's not hemoglobin, Pookie? Well, unless someone is running the marathon with a red blood cell transfusion, it's unlikely that this is going to be a red cell problem. Crush injury. Now, increased CPK should be done, but increased CPK is not as important as seeing if it's inside the urine. Urine myoglobin is even better. However, urine myoglobin can't be gotten instantly. Urinalysis, dipstick positive for blood but no cells seen. Hemoglobin, myoglobin, red blood cells. Hemoglobin, myoglobin, red blood cells. Hyperkalemia, EKG. Hit with a truck. Seizures protect the heart. Seizures crush severe exertion. You see that? Now, hypokalemia is here. Does not mean you get hypokalemia from rhabdomyolysis. It means hypo, low potassium, causes rhabdo. Low potassium is the etiology. See this thing where it says etiology? This would be a very easy mistake to confuse this and think that hypokalemia was the result of rhabdomyolysis. No. Hypokalemia is a cause of rhabdomyolysis. Rhabdomyolysis results in high potassium. But low potassium can cause such damage to the muscles as the muscle cells actually break down and release potassium inside the bloodstream. Now, the other causes of things that are toxic to the kidney tubule is that the myoglobin is toxic to the tubule, it precipitates in the tubule, and in the terms of the amount of time that that toxin's in contact, that's why the treatment for rhabdomyolysis is to hydrate the patient, mannitol and osmotic diuretics, and bicarb. Bicarbonate prevents the precipitation of the pigments in the tubule. Hydration and mannitol as an osmotic diuretic decrease the contact time. They decrease the contract time. So you see here in this slide, the tubule toxin, it precipitates. Bicarb prevented precipitating. Directly proportional to the duration of contact. Mannitol and hydration decrease the duration of contact, flushing it out, flushing it out. And since the dehydration makes it worse, because there's low flow, we water them and give them mannitol. It's really not any different than if somebody poured hot water on your hand that you go to the sink and rinse it off with cool water. Let's decrease the duration of contact and get that stuff off of you before it burns me. It's not any different than spilling a hot cup of tea. Pour hot cold water on you to dilute it off. Now, let's look at the other details and let's say some more things about rhabdomyolysis. Severe crush. Now remember is that if you go to the gym and do 50 push-ups, you're going to get an elevation in your CPK, but you're not going to get an elevation in your CPK high enough to cause renal failure. Seizures is like a crush is like a seizure. I want to be clear, you only give calcium gluconate or chloride if you see EKG changes. If you don't see EKG changes, you don't need to give calcium chloride. You see on the urinalysis, it's dipstick positive for red cells, but you don't see it, and that means if you see dipstick positive, the dipstick can be positive with red cells, hemoglobin, myoglobin. Now, CPK, remember, in order for it to be causing renal failure, you can't be elevated twice or 3 times or 5 times. In order for it to be causing a rhabdomyolysis and renal failure, it has to be elevated 10 times, 20 times, 50 and 100 times the upper limit of normal, enormously elevated. Now, anytime you get potassium problems causing EKG changes, you're going to give calcium gluconate or calcium chloride. That is not by itself specific to just rhabdomyolysis. That's any cause of hyperkalemia. You give calcium chloride or calcium gluconate. If you have hyperkalemia but no EKG changes, what else do you use to drive the potassium into cells? The answer is insulin and glucose or bicarb. Insulin and glucose or bicarb. You see here that we say bicarb, alkalinizing, because the alkalinization actually prevents the precipitation of the myoglobin at the kidney tubule. Mannitol and hydration decrease the contact time. Now, proteins of various forms. Bence-Jones proteins are directly toxic to kidney tubules. Light chains, parts of light chains, are directly toxic to kidney tubules. Bence-Jones proteins. There are a number of reasons that myeloma kills the kidney. Myeloma makes Bence-Jones proteins. Myeloma makes amyloid. Myeloma makes hypercalcemia. Myeloma makes amyloid, Bence-Jones proteins, hypercalcemia, and myeloma also results in antibodies that are going to clog up your glomerulus. So that is why the second most common cause of death in myeloma is renal failure. How you die in myeloma? Renal failure and infection. Renal failure and infection. Why? Multiple myeloma causes you to have Bence-Jones protein. Myeloma causes you to have high calcium. Myeloma causes you to have amyloid. Myeloma causes you to have lots of reasons for kidney damage: hypercalcemia, amyloid, bench-Jones proteins, and immunoglobulins. The most common causes of death in myeloma are infection and renal failure. Crystals. What case you're going to look for is you're going to look for a guy who's trying to commit suicide with ethylene glycol. Ethylene glycol. People who are depressed and committing suicide with ethylene glycol are going to be described as a person who's drinking antifreeze. Antifreeze. And antifreeze gives you ethylene glycol. Ethylene glycol is metabolized to oxalic acid. Ethylene glycol is metabolized to oxalic acid. And as it precipitates into oxalic acid, it binds calcium and makes calcium oxalate crystals. Remember, methanol hurts your eyes. I drank myself blind drunk because it causes optic neuritis and burns your eye. I drank myself blind drunk. Methanol causes blindness. Ethylene glycol causes renal problems by calcium oxalate stones. The two forms of stones we're worried about is oxalate and uric acid. Oxalate and uric acid. Acute renal failure with oxalate, ethylene glycol. Antifreeze overdose. Metabolic acidosis. Methanol and ethanol and ethylene glycol, 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 increased anion gap, metabolic acidosis, oxalate crystals, low calcium oxalate crystals. Best initial test, you see these envelope-shaped crystals? You know why they're called envelope-shaped? Because they're shaped like... You are so smart. You are so smart. You're beautiful, intelligent, smart, knowledgeable, capable. You don't even need me anymore. 2 seconds from now, you're going to see envelope-shaped crystals. And you go, oh my God, it looks like an envelope. Okay, it looks like an envelope. You treat it with alcohol, let's see. You treat it with ethanol or fomepizole. Ethanol and fomepizole prevent the production of the oxalic acid. Ethanol and fomepizole prevent the production of the oxalic acid. Dialysis is used to get the oxalic acid off of you. Ethanol and fomepizole prevent the production of the oxalic acid. Dialysis removes the oxalic acid from your blood and removes the ethylene glycol from your blood. Why does Crohn's disease cause high oxalate? Why does Crohn's disease cause high oxalate? Well, Crohn's disease, what effect does Crohn's have on fat absorption? Crohn's disease results in a fat malabsorption. So what happens is that normally what happens is that calcium and oxalate go out in the stool together. But what happens is that the problem here is that the fat stays in the gut and goes and binds to the calcium. So calcium gets bound up with fat. The oxalate's got no date. So instead of going out on its usual date, which is the calcium into the stool, the calcium is now with the fat and the oxalate gets hyperabsorbed, overabsorbed. Overabsorbed oxalate because calcium is now bound to the fat instead of the oxalate. These are the oxalate crystals. This is a very good picture to show you. Here's more of them looking like envelopes, envelopes, envelopes. Now, uric acid crystals. The only way to really get it is that acutely tumor lysis syndrome. Remember, when you give chemotherapy for lymphoma or leukemia, the cell nuclei have purines and pyrimidines in them. The cell nuclei have purines and pyrimidines. Those cell nuclei with purines and pyrimidines, the other name for purines and pyrimidines is nucleic acids. So therefore, the nucleic acids with urate tumor lysis syndrome is one of the only ways to get renal failure from acute uric acid buildup. That's why before people with leukemia and lymphoma get their chemotherapy, we hydrate them and give them allopurinol. Allopurinol prevents the formation of the uric acid stones and crystals in the kidney. Uric acid stones happen from tumor lysis syndrome acutely. Here are our uric acid. You could tell me this is a leopard spots, or this is a picture of the bottom of the Atlantic Ocean. Could be uric acid crystals. Now, other forms of uric acid crystals. Remember, this is on a urine. This is not looking into joints. Uric acid crystals in joints, you may be thinking of negative needles, negatively birefringent needles. But that's on joint fluid, not on a urine. Ah, here it is in joint fluid. Uric acid crystal, negative needles, negatively birefringent needle-shaped crystals. What is pseudogout? Pseudogout is positive rhomboids, positively birefringent rhomboids. These are negatively birefringent needles. Rhomboids, positive rhomboids is pseudogout. Hypercalcemia. Kids causes stones. Hypercalcemia causes tubular acid defects, tubular acidification defects. Hypercalcemia blocks the effect of ADH on the kidney tubule. Hypercalcemia causes stones, causes a distal RTA, blocks the effect of ADH on the kidney tubule. By far, the single most common cause of hypercalcemia in the United States is increased parathyroid hormone. Unless it says that the person has stones, or has renal insufficiency, or has some form of acute symptoms, a hyperparathyroidism without stones or renal insufficiency does not need to be treated. A hyperparathyroidism without stones or renal insufficiency does not need to be treated. A hyperparathyroidism without stones or renal insufficiency does not need to be treated. Does not need to be treated. If the hyperparathyroid, do you know that right now you could be hyperparathyroid? You have a little high calcium. You've got no symptoms, no stones, no renal damage, nothing. But you got hyperparathyroidism. Would you want neck surgery to get the parathyroids taken out? Or would you say, I don't bother the calcium and the calcium does not bother me? Would you want your neck dissected for that? I don't know. What we know is that symptoms, the parathyroid should come out. No symptoms? Yeah. I got renal insufficiency? Kidney stones? Decreased renal function of any kind? Leave it alone. Leave it alone. Leave it alone. Why does calcium block the effect of ADH on the kidney tubules? Because it does. You like that answer? Because that's the way it is. Because I'm the daddy, that's why. ACE, that's the way it is. Now, the two electrolyte problems that cause the diabetes insipidus are hypercalcium, high calcium, low potassium, high calcium, low potassium, and you have nephrogenic diabetes insipidus. Oh, look at this. Is that a chicken McNugget? No, that's a 5mm stone. That's the upper limit of how much of a stone you can pass spontaneously. It'd be very hard to get even anything above 4mm into the ureter. Up to about 5mm stones can pass spontaneously. 6, 7, 8mm generally don't pass because the ureter is not wide enough to accept them. It provokes excruciating pain, and that kidney stone, when it's above 5mm, would probably have to be removed by lithotripsy. But it does look like a chicken McNugget. Now, ooh, a stellate. You like stellate? I like the word stellate. That's a $5 word for star. Looks like a star. Stellate. Urolith. Urine stone. Doc, I think I've got a urine stone. No, you have a urolith. Oh, gee, thank you, doc, for the diagnosis. Large urine stone in the form of a star. That means a bladder has got a star. You're not going to pass that one through your urethra. So that one would have to be passed out surgically. Now, staghorn calculi means that this thing is so huge, it can only be removed surgically. Remember, things that are stones up to about 5mm will pass spontaneously. But a huge staghorn, gee, it looks like a stag. What's a stag? A large male deer, a four-legged animal with big horns. Well, that looks like a deer's horns. It won't pass out. A stag's horn. For those of you who can remember what a stag is, a male deer. You like that? So it's a staghorn. It won't pass out. It's far too big. It has to be removed surgically. Now, it's possible on kidney stones to stick a sonogram and a lithotripter right into the kidney. What happens if you have a stone that's too big to pass spontaneously, but you don't want to do surgery? Put a lithotripter right into the bladder, right into the kidney, and boom! Blow it up in sight and pull out the pieces. And pull out the pieces. Amazing, amazing. Anything to prevent you from having to cut my side open. Remember, the kidney is a retroperitoneal structure that's above the level of the ribs. This is not just like popping a pimple here, you know what I mean? So therefore, in order to get that out, you'd either have to crack them open like pulling the pit out of a mango, or you can put a lithotripter right into the kidney from the side, percutaneously, blow up the stone, and irrigate it out in pieces. Amazing, wonderful. Forget the surgery. Lithotripter right into my side. Boom. Now, the last subject in acute renal failure for things that are directly toxic to the kidney tubule. What is different about these toxins, aminoglycosides, cephalosporins, contrast, amphotericin? What's different about these toxins from the allergic interstitial? These toxins, aminoglycosides, cephalosporins, but in particular aminoglycosides, contrast agents, these need more time. Aminoglycosides, 5 to 10 days. The other thing is there is no specific diagnostic test to diagnose aminoglycoside-induced, amphotericin-induced, cyclosporin-induced renal failure. You have to exclude the other things. I exclude the eosinophils. I don't see any blood in the urine. There are no crystals in the urine. There's no calcium or crystals or uric or oxalate. And I see the toxin in the history. I see the toxin in the history of the toxin. I see the aminoglycosides in the history of the toxin. And I have excluded the other diseases with the urinalysis and the blood testing. Now, since there's no specific test, in other words, somebody has creatinine rising, there is no test I could do that says it was an aminoglycoside. I have to exclude the other things and look in the toxin in the history. I have to exclude the other things and look at the toxin in the history. There's also nothing to reverse it. There is no medication to reverse aminoglycoside-induced nephrotoxicity. There is no medication that I can give to reverse amphotericin on the kidney, reverse cyclosporin on the kidney. There's no medication to reverse it. It's like a sunburn. You stop the toxin and you wait for it to reverse. Aminoglycosides. We think, if you look at the low potassium and the low magnesium, we think that low magnesium and low potassium increases the tubular cell pickup of the aminoglycoside. We know that low potassium and low magnesium provoke or make the aminoglycoside toxicity more likely. Why do you get a high creatinine? Because amphotericin is directly toxic to the kidneys. Why do you get a low potassium and a low bicarb with amphotericin? This is renal tubular acidosis, type 1 renal tubular acidosis. Here's a new one. Here's a new one. Atheroembolic disease. Atheroembolic disease. Atheroembolic disease is going to be a person that's going to say, we got a 60-year-old guy who undergoes a catheter procedure with contrast, like an angiogram. And it's going to say, later that night, the following day, he's got blue toes, bluish discoloration, and livido reticularis. Reticulum means a net. It's like blue fishnet stockings. So you say to the guy, oh my God, those are some beautiful blue fishnet stockings you're wearing. And the guy says, I'm not wearing any stockings. Those are my veins. Blue fishnet veins. Livid. Livid means turning blue. Someone says, I'm livid. Ooh, I'm turning blue with being upset. A blue net on the legs. Why do you get eosinophils? Not clear. Why do you get eosinophils? You get eosinophils, you get low complement. What is the treatment for atheroembolic disease? There is no treatment. The biggest question for contrast-induced atheroembolic disease is that what can you do to prevent it? Atheroembolic disease, there's nothing to prevent it. You see blue toes, livido reticularis, eosinophils. the single most accurate test would be to biopsy one of those bluish discolorations. You can actually see cholesterol crystals inside the skin. What should you do? Don't biopsy. I had a catheter procedure. It dislodged some atherosclerotic plaques, which went embolic to the skin and turned them blue. The biggest issue is going to be the question called, what can you do to prevent contrast-induced renal failure? A 60-year-old guy with a history of diabetes and hypertension has a very mild increase in his creatinine. A very mild increase in his creatinine. What can you do to prevent that person from having renal failure worsening? And the answer is hydrate and N-acetylcysteine. Hydrate and N-acetylcysteine. Hydrate N-acetylcysteine bicarb. What can you do to prevent? Because there's nothing to do to treat it. Atherembolic disease. I had a catheter procedure. It dislodged some cholesterol emboli. I get blue toes, low complement, high eosinophils, livido-reticularis. Although the most accurate test is to biopsy the skin, don't do it. How can you prevent contrast-induced renal failure? Hydrate and N-acetylcysteine. What can you do to prevent it? Ooh, look at these non-steroidals. Non-steroidals do all sorts of evil things. Look at this. Non-steroidals are directly toxic. Non-steroidals cause allergic interstitial nephritis. Holy eosinophils, Batman. Non-steroidals inhibit the prostaglandins, and the prostaglandins dilate the afferent arteriole. The prostaglandins dilate the afferent arteriole. Now we've constricted. Non-steroidals actually can cause membranous glomerulonephritis. Non-steroidals are particularly bad in those who have underlying renal failure. Remember, you lose 1% of nephrons per year past the age of 40. 1% of nephrons per year past the age of 40. So if you're 70 and 80 years old, you've already lost 30 to 40% of your kidney. So non-steroidals. Now the only one that we haven't said specifically before is papillary necrosis. Papillary necrosis. Papillary necrosis is going to present like a person who looks like they have pyelonephritis. It's going to say, well, a person who's got sickle cell, because these people have bad kidneys to begin with, takes a bunch of non-steroidals. Now they have flank pain, fever, and inside the urine they have pieces of material, necrotic material being passed. It's very sudden. It's after non-steroidals. It's associated with sickle cell. Non-steroidals associated with sickle cell. The urine has strange necrotic material being passed into it. Papillary necrosis. What is the most accurate test? A spiral CT. What is the therapy for papillary necrosis? There is no therapy. Here you have a kidney. Here's our kidney. Whoa, that's a beautiful kidney. Now the renal papilla, isn't that beautiful? Oh, I'm so proud of myself. The renal papilla slough off, and you have pieces of kidney parts now passing into your urine. Sudden, non-steroidals, sickle cell, looks like pyelonephritis, but no white cells and sudden. No white cells and sudden. Diagnostic test, CT scan. When is intravenous pyelogram the answer on your test? When hell freezes over. Somebody says IVP, you say no. IVP? No. IVP? No. IVP? No. IVP? No. That's operant conditioning. Hold your hand out. IVP. Ow! Hold your hand out. IVP. Ow! IVP. IVP. Oh! No IVP. IVP. No. IVP. Contrast. Why do I want to give contrast to a person with renal failure? Change it from calling it a die reaction, call it a kill reaction. Why do I want to give a test that takes hours? IVP, intravenous pyelogram. Spiral CT, 10 minutes and less toxicity. Papillary necrosis, no treatment. No treatment. Oh, look at this. What a shock. Papillary necrosis, sickle cell disease, and diabetics. This is really saying, hey, who's got underlying renal disease? Sickle cell underlying renal disease, diabetes underlying renal disease, obstruction underlying renal disease, chronic pyelonephritis underlying renal disease. Hey, look. It looks like a person who's got pyelonephritis. And now your CT scan shows that it's bumpy. Look up, because it's bumpy and lumpy because I just sloughed off part of my kidneys. Oh, hey, lumpy, call me bumpy. Lumpy, bumpy, no therapy. What can you do to prevent contrast-induced renal failure? Hydrate, bicarb, N-acetylcysteine. Hydrate prevents the duration of contact of the contrast with the kidney tubules. Hydrate decreases duration of contact. Hydrate decreases duration of contact. Bicarb and N-acetylcysteine prevent the precipitation of the contrast on the kidney tubules, we think. We just know that they're somewhat effective. Hydration, bicarb, N-acetylcysteine. Preventing. Wow, you have survived acute renal failure. Check your urinalysis and see if you've developed rhabdomyolysis from sitting for so long. But remember, you don't need to give yourself calcium chloride or calcium gluconate unless your EKG shows EKG changes. Remember, with a severe crush, even though you want to check the urine to see if you got pissed off, even though you want to check the blood to see if there's a high CPK, in a severe crush, the first thing to do is always to think about the other person's heart. I will see you in the next section.